Hi, I'm Keith Sullivan, Professor of Medicine in the Division of Hematologic Malignancies and Cellular Therapy at Duke University. And together with Dr. Suzanne Ildstad, we're going to have an exciting program to discuss facilitator cells and how, when applied to allotransplantation, either renal transplantation or hematopoietic stem cell transplantation, can improve the outcomes of allografting. The learning objectives will be to describe how did the facilitator cell come to be, what is its role in being a tolerogenic avenue for transplantation, review the results of the living donor human renal transplant study and how this may be applied in a well-designed trial for systemic sclerosis, severe scleroderma. I'd like to introduce Dr. Suzanne Ildstad, who is a consummate physician scientist and inventor, well known in the transplant community for her discovery of the tolerogenic graft facilitating cell. Her training included an MD from Mayo Medical School, surgical residency at Mass General, an immunology fellowship at the NIH, and a transplant fellowship at Cincinnati Children's. She has been elected to the National Academy of Medicine and elected to the National Academy of Inventors. It is a great honor to share the podium with her and this program with you, Dr. Ildstad.
Thanks very much for the introduction, Keith. I will be talking today briefly about the journey of the facilitating cell from essentially mouse to human. And then Dr. Sullivan will follow up with an overview of the use of bone marrow transplant in various autoimmune diseases. I'm a transplant surgeon by training, and I saw firsthand the challenges that patients who undergo a kidney transplant see and encounter throughout their lifetime. And as a result of that, essentially, people for over 50 years have been exploring ways to induce allogeneic tolerance, or where a process where the recipient sees the donor as part of self. Essentially, the key challenges in transplantation are the rejection of the organ, loss of self-tolerance, and also graft versus host disease, where the donor graft attacks the recipient. And obviously, if one can induce tolerance, it enables the donor stem cells to coexist with the recipients in non-confrontational manner and where they're mutually tolerated. And there's a functional immune and blood cells of both donor and recipient that are produced. The goal of our therapy and our preclinical work was to establish chimerism, or a dual recipient and the transplant recipient, which allows both donor and recipient cells to mutually coexist. And work that led up to being able to apply this in the clinic was identifying methods to induce tolerance across HLA mismatched donor and recipient pairs, and also avoid the toxicity of myeloablative conditioning, which Dr. Sullivan will be discussing for some of the protocols actually in autoimmune disease, and identify a reduced intensity conditioning approach to allow transplantation to be justified in both solid organ transplant recipients and in patients with autoimmune disease. We used a mouse model of non-myeloablative conditioning and identified that 200 centibray of total body irradiation in combination with post-transplant cyclophosphamide allowed chimerism to be established across major MHC disparities without causing graft versus host disease, and in a very non-myeloablative way. We identified in the bone marrow a unique tolerogenic non-stem cell that we call the facilitating cells using rare event cell sorting. The facilitating cell is CD8 positive and T cell receptor negative. And we used a mouse model where we purified stem cells and purified other cells in the bone marrow and identified what cells were necessary and sufficient for stem cells to engraft in mismatched recipients. And that resulted in the discovery of the facilitating cell. And our FCR-001 approach is based on that cell in addition to a well-defined product with a minimum target dose of hematopoietic stem cells, a minimum target dose of facilitating cells, and a fixed amount of very low numbers of alpha beta T cells. The reason that the alpha beta T cells are important is not that they're required for the stem cell to engraft, but that they, in the face of non-myeloablative conditioning, where if it's very low intensity, you have residual recipient cells that can react against the donor early after infusion. Those alpha beta T cells of donor origin counter the recipient alloreactive cells in optimizing engraftment. And so the combination of non-myeloablative conditioning and the FCR001 product have allowed us to establish chimerism in mismatched recipients up to 0 of 6 matched or 0 of 12 matched and unrelated donor recipient pairs. We know quite a bit about the mechanism of the function of the facilitating cell. This slide shows the various effects that the facilitating cell has on both recipients and on engraftment of the stem cells. The red publications are publications from groups that have reproduced or extended our work. The black publications are publications from our own laboratory. And you can see that if you go across the top from left to right, the facilitating cell induces IL-10 producing regulatory B cells in vivo and in vitro. It induces antigen-specific regulatory T cells in vivo and in vitro. And that's both the FOXP3 positive Tregs and the IL-10 TR1 cells. And the facilitating cell has a number of effects on stem cells in terms of promoting survival. It prevents apoptosis of stem cells and enhances clonogenicity. In gene arrays of mouse and human FC, we see a strong B cell signature. And again, it's a more tolerogenic signature. The facilitating cell enhances homing and migration of stem cells, and it also prevents graft versus host disease in mice through ALDH, actually. And that's a manuscript that has been submitted now and is under review. Our initial focus with this technology has been in organ transplantation, specifically in living donor kidney transplants, which is our most mature program. We have a phase 3 study called Freedom 1 that was initiated in 2021 to transplant living donor kidney transplant recipients to attempt to induce tolerance. We also have underway phase 2 approved to proceed from the FDA, a study that we call Freedom 2, which applies to patients who had a prior living donor kidney transplant and will be essentially tolerized to their donor at a later date or in a delayed fashion. And that study was initiated in late 2021. And we also have underway a preclinical deceased donor study using vertebral marrow from deceased donors that will open the door for a number of other solid organ transplants, including liver transplant, lung transplant, heart, pancreatic islets, and various other tissues. We have, in addition, because of the platform nature of our technology, we have a phase 2 approved to proceed that is now underway called Freedom 3, which is in a phase 2 in scleroderma. And Dr. Sullivan will be talking in more detail about that. This will open the door potentially to other rare autoimmune and immune-mediated diseases, of which there are greater than 80 that have been recognized. In our phase 2 study of the living donor kidney transplant patients, we found that we could indeed induce tolerance without a high rate of graft versus host disease. Our inclusion criteria really included what is normally used for living donor kidney transplantation. One major exception as it pertains to the bone marrow community is we did not require HLA matching. So we began with relatively closely HLA matched living donor kidney pairs and then expanded. And you'll see from further data that I'll show the degree of match or mismatch and whether they were related or unrelated did not have an impact on the success. We were able to cross major HLA barriers without compromising engraftment. Our key exclusion criteria, again, were pretty much related to what is normally done in kidney transplantation, with the exception of the excluded unrelated female donors to male recipients after 2 cases of graft versus host disease, which I'll talk about in a minute. Our study consists of the standard approach for 200 centigrade of TBI based irradiation plus post-transplant cyclophosphamide on day plus 3 days of fludarabine, which is a little bit less intense conditioning than is used in the Fred Hutchinson Cancer Center and the Johns Hopkins people who pioneered this approach in humans. Essentially, the patients are monitored for 6 months and maintained on standard immunosuppression, meaning mycophenolate mofetil and tacrolimus. At 6 months, they undergo a biopsy and renal function testing and testing for chimerism. And if they have greater than 50% donor chimerism and no graft versus host disease and a normal biopsy, the MMF is stopped. Then the tacrolimus is maintained but weaned down to very low trough levels over the next 6 months. And at 12 months, the patients again are tested by biopsy and for chimerism, and the immunosuppression is stopped if they have high levels of donor chimerism, T cell chimerism greater than 50%, and a normal biopsy and normal renal function. This slide shows the summary of our kidney transplant results as of January 31st, 2021. 70% total of subjects had stable chimerism and were able to be weaned off immunosuppression and have been maintained off immunosuppression. None have had to go back on. Actually, halfway through the study, we identified the minimum target threshold dose of stem cells and facilitating cells. And at that time, subsequently, our success rate was actually 82%. You can see on the right-hand side of the 37 patients transplanted, 27 had chimerism. One developed a complex presentation of graft versus host disease and CMV colitis that was tissue invasive. And he had high levels of donor chimerism, presented very late for treatment of his GVH, and unfortunately expired from a septic episode at month 9. 26 of the patients were completely weaned off immunosuppression and maintained durable chimerism. There was one patient in that cohort who, during conversion from a CNI inhibitor to sirolimus, developed grade 2 graft versus host disease. He responded to steroids. He was not covered with steroids during the conversion. He responded to steroids and eventually was weaned off all immunosuppression, has durable chimerism and stable renal function with low-grade chronic graft versus host disease. But you can see that of the 37 patients transplanted, then 26 have been weaned completely off immunosuppression and have maintained stable renal function. We did have a handful of patients who had lost their kidney related to an autoimmune disease who were evaluable. 7 of those patients, as shown on the far left, were chimeric and off immunosuppression. None of them developed post-transplant disease recurrence. And within that cohort, there were 2 patients with FSGS, which tends to return in a pretty high proportion of patients, and it tends to return very early. And you can see that no one relapsed with this. Of the patients who only had transient chimerism, of which there were 3, 2 actually had post-transplant recurrence. So these data, although it's very small numbers, would suggest that chimerism really contributes to halting disease recurrence and disease progression. We found that the level of chimerism was very predictive of being able to wean patients off immunosuppression. especially T-cell chimerism. And our focus was essentially, our goal was to have greater than 50% donor T-cell chimerism. And you can see here that most of the patients actually had much higher levels of donor T-cell and whole blood chimerism. The blue line is the T-cell chimerism, the red line is the whole blood. You can see by 3 months, 90% of patients who achieved chimerism by month 3 were able to be weaned off of chronic immunosuppression. And 96% of patients who achieved chimerism by month 6 were able to be weaned off chronic immunosuppression. And all 26 patients weaned off chronic immunosuppression by month 12 have remained off of immunosuppression and have had no rejection episodes and no donor-specific antibody identified. Our median follow-up is greater than 6 years, and our longest follow-up now is greater than 11 years. This slide shows the degree of HLA matching and relatedness. So LRD off immunosuppression means living related donor off immunosuppression. The lighter blue is the transiently chimeric patients who were not taken off immunosuppression. The dark orange is the living unrelated donor off immunosuppression, meaning that they're chimeric. And the lighter orange is the living unrelated donor that were transiently chimeric and were not taken off immunosuppression. And you can see that in this cohort of patients, a very high proportion were essentially unmatched and unrelated. And the degree of chimerism and success was not in any way influenced by the degree of matching or mismatching. So in terms of recipient safety, as a summary, no acute rejection or de novo donor-specific antibody occurred in patients off immunosuppression. There were a total of 3 graft losses, one at 3 months, one at 9 months, and one at 47 months. And these were all patients who were not chimeric, who were not able to be weaned from immunosuppression, and some of whom were actually non-compliant. There were 4 deaths that occurred. The grade 3 graft versus host disease that I summarized, it's CMV, GVHD colitis. There was 1 patient who had pneumococcal sepsis after traveling abroad, who had not been revaccinated per our stem cell protocol recommendations. 1 patient expired at 4.5 years from lung cancer. He was a very heavy smoker. And 1 patient who was not chimeric expired at 4.5 years from respiratory failure secondary to septic shock and aspiration pneumonia. And unfortunately, this does happen in standard of care kidney transplant recipients. We had a total of 2 GVHs, which I previously described. 1 with grade 2, who occurred during conversion from CNI inhibitors to sirolimus and responded to steroids. And that patient is now off immunosuppression with chronic musculoskeletal symptoms. And at this point, I will turn this over to Dr. Sullivan, who will talk about the role of systemic sclerosis and HSCT and autoimmune diseases. Thank you very much.
Thanks, Dr. Ildstad. I'd like to then shift into how this facilitator cell transplant regimen might be applied in systemic sclerosis. As transplanters, we're all too familiar with scleroderma as a cutaneous manifestation of chronic GVHD following allogeneic transplantation. The natural form of this severe autoimmune disease occurs over time. And shown here, increasing skin thickness, there is also involvement of the lung, the heart, and the kidney, leading then to morbidity and mortality. The figure on the right is a survival curve from the Royal Free Hospital. These are patients with systemic sclerosis, scleroderma, with internal organ involvement. And mortality is progressive over the years. When I first showed this to our own faculty, I was questioned, Keith, what cancer is that? So this is a serious disease. It's devastating. And unfortunately, there has been no change in the mortality over the preceding 40 years. despite applications of disease-modifying anti-rheumatic drugs, immunosuppressants, antifibrotics, and biologics. Stem cell community comes into this story based on some preclinical data that were published in 2 articles in the mid-80s in PNAS, one by Dirk van Beckum, who used an animal model of induced autoimmune disease, adjuvant-induced arthritis, followed with total body irradiation and auto transplants. And in that model of environmentally induced disease, the disease did not progress, and in fact, it reversed. The other pathway where individuals can develop an autoimmune disease is not only environmental conditions, but also genetic predisposition. To that end, Dr. Robert Good employed allogeneic transplant, total body irradiation, TBI, and allografting in animal models of genetic disease, such as lupus and diabetes. And these were impressive findings, where not only did the progression of the disease reverse in the animals after transplant, but in fact, the organ involvement shown by histopathology of the kidney, for example, in lupus went back to normal. So the question is, what is the outcome in humans? Well, the first experiments were combined. These were individuals who underwent allografting for hematologic malignancy who happened to have autoimmune diseases, and both improved after allografting. Then there became a literature of case reports of autologous transplantation for autoimmune disease. And this is best summarized in this really important study by John Snowden, published recently in Blood Advances, which is the EBMT experience of transplant for autoimmune disease. These are over 2,000 transplants from 1994 to 2015 shown here. In blue are the allogeneic transplants. These are mostly non-myeloablative conditioning regimens. And here is a smaller subset of individuals who underwent allogeneic transplant. The largest book of business was for multiple sclerosis, followed by systemic sclerosis, scleroderma, and the other autoimmune diseases. And what John found was there were better outcomes when the center, and these were 247 centers, when the center had experience of a certain number of cases done for autoimmune disease, and they had time under the belt where rheumatologists, neurologists, and the stem cell transplanters were collaborating for the care of the patient, as well as stem cell transplant accreditation. I'd like to break these data down because there were some findings over time. Here is each of the 5-year time blocks. And as you can see, initially the transplant-related mortality in these mostly autografts, mostly non-myeloablative regimens fell and progressively fell, so it's now about 3%. But highlighted also in blue is the fact that even though recurrence of autoimmune disease, relapse, fell in the first time period, it did not change in subsequent years and remained about 35%. Now, in reference, the recurrence rates in the ASTIS trial was 12 to 24 months was 22%. And in the Scott trial at 54 months was 9% after a myeloablative regimen. And here is the Scott arm that was chemotherapy only. The right-hand column represents autologous transplants in this EBMT experience. And as you can see, that there is progressive recurrence of disease over time without any evidence of a plateau. Fortunately, after autografting, non-relapse mortality, as I showed in the previous slide, was about 3%. Contrast that to a smaller group, but the allogeneic patients had a lower rate of relapse, about 20% compared to 35+%, but had an increase in non-relapse mortality from 3% to 20%. So the goal is, could we then make an allogeneic transplant safer and still benefit from lower rates of recurrent disease? Well, to reach the rheumatology community, Stephanie and I placed an article kind of giving a framework of principles to consider when you're choosing auto or allo graftings. First of all, everyone, if you have a trial, should be enrolled in the clinical trial, and transplants should be performed at experienced centers with collaboration with rheumatologists, neurologists, and transplanters. Transplant earlier in the course of disease before organ failure. And for children with an HLA-matched bone marrow donor where GVHD will be least, you could consider transplant. However, for adults, currently the evidence favors autologous transplants over allogeneic transplants. But an important caveat is whatever the type of transplant or regimen, patients should be monitored lifelong for toxicity and relapse by a multidisciplinary team and results reported to the registries. This then leads into the challenges in future trials. And allogeneic trials, can regimen-related toxicity be reduced, and can GVHD be eliminated? For autografting, can we lower the rates of recurrent disease? And for both allos and autos, can we change payer and physician practices to refer patients to our centers? And can sicker patients be transplanted? And do we have better, newer approaches to make transplants safer? That comes full round to what you saw in the previous talk about the use of facilitating cells, which may in fact widen the application of transplant, reduce regimen toxicity, and reduce recurrence. This is what's then been designed in the single-arm multi-center open label trial, so-called Freedom 3. In Freedom 3, these are adults over the age 18 in a single-arm study with entry criteria similar to Scott, individuals who have internal organ involvement. The primary objective is to define SAEs and AEs, GVHD, and a variety of secondary and exploratory outcomes. And importantly, the study design is based on what you've already seen by Dr. Ildstad in the human living donor renal transplant study. So fludarabine, 30 per meter times 3, and cyclophosphamide 50 per kilo times 1, 200 centigrade TBI, and the infusion of the facilitator cell, followed with immunosuppression of mycophenolate for 6 months and tacrolimus for 12 months, and post-transplant Cy times 1, with a readout at the primary endpoint analysis at month 24. So this study is already open at Michigan. It will soon be open at Duke, and we're enlisting several other centers to get experience with this type of approach of trying to create a allogeneic transplant for autoimmune disease with reduced toxicity and with reduced GVHD. So I thank you for your attention and for your questions.